We are talking about some key concepts today related to the lungs and how circulation occurs and the details within that. To start off here, we're going to talk a little bit about membranes, pressures, and negative pressure ventilation. So to understand how we breathe, we need to talk about the pressures and membranes involved. So in the thoracic cavity, it is lined by the parietal pleura, and the lungs are covered by the visceral pleura. Between them, a very tiny space is the pleural space, which normally has a slightly negative pressure. And this negative intrapleural pressure keeps the lungs inflated. And during inspiration, diaphragm contracts and the thoracic volume increases, which creates a more negative intrapleural pressure, allowing air to flow into the lungs. Expiration is usually passive, where the diaphragm relaxes and pressure returns towards the baseline. And moving on to the pneumothorax. So a pneumothorax happens when air enters into your pleural space, which leads to a collapsed lung. So when you hear pneumothorax, it's equivalent to collapsed lung. This can occur from trauma or can also occur spontaneously. When that negative pressure is lost, the lung can't stay expanded, so it recoils inwards. So that negative pressure that was in the intrapleural space, or in the pleural space, is lost, and so then the lung just squeezes up into a little ball. So a tension pneumothorax is especially dangerous. It shifts the mediastinum, which compresses the heart, and opposite lung. Immediate intervention with something like a needle for decompression is really important in that instant. Now we're going to hit a little bit on surfactant, surface tension, and Laplace's law. The alveoli are lined with a fluid that creates surface tension, which without a solution causes the alveoli to collapse. So that's where surfactant comes in. It's a substance produced by type 2 alveolar cells and reduces surface tension. According to Laplace's law, pressure equals 2 times tension divided by radius. So smaller alveoli would have higher pressure and collapse without surfactant. In preterm infants who lack surfactant, it leads to neonatal respiratory distress syndrome. And so they give them an injection that allows them to directly create this surfactant. Surfactant makes breathing much more energy efficient by stabilizing alveoli of different sizes. Now a little bit on the alveolar gas equation. The alveolar gas equation allows us to estimate the partial pressure of oxygen in the alveoli, or the PaO2. And it's calculated as this equation here. PaO2 equals FiO2 times Pa, the pressure of atmospheric, minus the pressure of water, all subtracted by PaCO2 divided by R. And so FiO2 is a fraction of inspired oxygen, which is usually around 0.21. Pressure ATM is atmospheric pressure, or about 760 millimeters of mercury. pH2O is water vapor pressure, which is about 47 millimeter mercury. And PaCO2 is arterial CO2 pressure, and R is the respiratory exchange ratio, which is about 0.85. So clinically, we compare the calculated PaO2 with the actual PaO2 from an arterial blood gas. A significant difference suggests impaired gas exchange, such as a diffusion problem or V over Q mismatch. And then a little bit on CO2 and O2 transport within the blood. CO2 is transported in the blood in three forms. You have dissolved in plasma, bound to hemoglobin as carbaminohemoglobin, and most importantly is bicarbonate via the carbonic anhydrase reaction. O2 transport is primarily bound to hemoglobin, and only a small amount is dissolved in plasma. The hemoglobin can carry up to 4 oxygen molecules, and its affinity changes based on several factors. And so there are a lot of hemoglobins within a red blood cell, and there are a lot of red blood cells. And so if each one's carrying around 4 oxygen molecules, it adds up very quickly. Alright, and finally, the oxygen hemoglobin dissociation curve. This curve shows how hemoglobin's affinity for oxygen changes with the partial pressure of oxygen. The right shift, caused by increase in CO2, increased temperature, decreased pH, or increased 2,3 BPG, reduces affinity, helping unload oxygen into tissues. A left shift does the opposite. It increases affinity, which can help in the lungs, but may reduce delivery to tissues. This dynamic relationship ensures that hemoglobin loads oxygen efficiently in the lungs and releases it where it is needed most. Alright, and that is all I have for this video. Thank you for listening, and hopefully you're able to understand these principles, which can help for both clinical and patient reasoning and care. And that is it. Thanks.